So we're here on behalf of Brazilian Glaucoma Society, and I'm just going to show a little ad from our sponsor here, and this will be very fast, and then I'll do Dr. Chauhan's introduction, and then we go straight for this for his lecture, and then if he has the time, we go over a little questions, and then that's it now.
Alex, just remind me, I have what, about 30 to 40 minutes? That's what you said, right?
Yeah.
Okay.
Whatever.
I'll try to finish in about half an hour, okay?
Sounds good. Okay. So little video. This interview is brought to you by... Oh, first I have to share my screen. Sorry. Sharing screen now. Can you see my screen now?
Yep.
Okay.
No sound?
I don't hear anything.
Okay. Stop sharing my screen now. Okay. For those ladies and gentlemen that don't know him, Dr. Chauhan is professor and research director of ophthalmology and visual sciences at Dalhousie University in Halifax, Canada. He obtained his PhD at the University of Wales, Cardiff, UK, and did his postdoctoral training at the University of British Columbia, Vancouver, Canada, under Dr. Drance's supervision. Dr. Chauhan's clinical research interests center on changes in the visual field and optic disc in glaucoma. He has devised new strategies for detecting glaucomatous progression and conducted research to translate them to clinical practice. Key contributions in this area were topographical change analysis, the TCA. We use it for identifying changes in optic nerve head topography with HRT, and his classical paper on practical recommendations for measuring rates of visual changes in glaucoma, published in 2008 in the British Journal of Ophthalmology. Over the past 10 years or so, he has put together significant and relevant work on the acquisition and analysis of anatomically and geometrically accurate neuroretinal rim measurements with OCT. Particularly in this late body of work, he has been collaborating closely with Dr. Burgoyne from Portland, and of course with Dr. Nicolella from his group. Dr. Chauhan has received numerous awards and recognitions, including the Achievement Award of the American Academy of Ophthalmology, Gold Fellow of the Association for Research in Vision and Ophthalmology, and the Alcon Research Institute Award. His research is funded by the Canadian Institute of Health Research, the Atlantic Innovation Fund, and other public and private sector agencies. Besides, he knows as much about wine as he knows about glaucoma, and he is a killer tennis player and squash player. Believe me, he is very good. Well, without any further ado, please tell us why what we have been taught about the optic disc is not entirely true.
Thank you very much, Alex. I hope you can all hear me. And I would love to share my screen with you if I can bring this on. Well, good afternoon or good evening, I should say, to everyone. Alex, thank you very much for that very generous introduction. Alex, those of you who don't know, spend some time in Halifax, and he's not serious about the squash because he actually is one of the most competitive players that I know, and he started off as a really terrible squash player. I hope you don't mind me saying that, Alex. And I actually particularly enjoyed beating him. And so by the end of his fellowship here, he got much better than me, and I wasn't very happy about that. So he's only saying that just to be nice, but we haven't played, but I'll take you on again. So anyway. So good evening, everyone. So what I want to talk to you about today is really some work which over the last 10 years have really questioned what exactly is it that we're looking at when we look at the optic nerve head. And of course, central to all this is the OCT and how OCT has really changed the way in which we do not just glaucoma, but ophthalmology entirely. I would say that perhaps in my career, it has probably been the single most important diagnostic device that's been introduced. And I don't take that lightly. I think that's a very important development. For those of you who have not been to Halifax, this is what Halifax looks like. Maybe 1 or 2 days of the year when it's not foggy, snowing, or whatever, but this is really the view of our university and our university tower. It's surrounded by the sea and it's really quite beautiful. I have really a lot of fond memories of Brazilian colleagues. So these are some of the Brazilian trainees who came to Halifax. Adael Soares, and I don't know if Adael's on this call, joined us many, many years ago, actually almost 20 years ago. Adael probably really dislikes me because I made him work so hard measuring vessel calibers. Alex was here, what 10 years ago now almost, and a lot of the work that I'm going to show was actually done by Alex. Jaime Viana, a dear friend, Jaime was here 3 or 4 years ago, and we succeeded in keeping him. So Jaime is now a staff member here. And Lucas Torres, who is in Curitiba, a dear friend also. He was with us, and we miss him a lot as well. And of course, as Alex has said, our boss, our department head, is Marcelo Nicolella, who you all know. So I'm very grateful to my Brazilian colleagues, and I have a very, very warm spot in my heart for all of them. Okay, so let's just go to a textbook. You open any ophthalmology textbook, and this is what the typical schematic of the optic nerve that they will show you. So on the top here, I hope you can see my pointer. The top here shows you the en-face view, or the ophthalmoscopic view of what the optic disc looks like. And we are supposed to believe that the optic disc edge and the optic disc cup correspond to some sort of physical structure here that you can see here in cross-section. And typically, the optic disc edge is thought to be some sort of a flange, either the edge of the sclera, the inner edge of the sclera, or the inner margin of the scleral ring or Elschnig's ring. And we don't really know what it is. But this is the classic diagram that's in the textbooks. But let's take a closer examination of this. And so if I take a fundus photograph of the optic nerve head, let me just do a schematic of it. And let's just go through this theory that the textbooks provide to us. If we take now a section through the optic nerve head where this red line is, here you can see what these structures correspond to, what the textbooks tell us. So these green dots here are supposed to line up to some tangible physical structure, which is either the inside edge of the sclera or of the border tissues of Elschnig. And we're told that it's an actual anatomical structure from which physical and quantitative measurements can be made. Now, the cup margin is a really nebulous structure. It's supposed to be based on a clinical appearance, on contour and not color, on the angulation of vessels and so on. But I think you'll agree with me that this structure here has absolutely no anatomical basis. In other words, it's based on contour, but there is no tangible reference when you look at the cross-section of the optic nerve head to what this is. And then what we are led to believe is that the difference between these two structures is supposed to give us something that's quantitative. So the cup margin then, again, is based on contour and angulation of the vessels. And then the rim is supposed to be something that's basically the difference between these two structures. And I'm going to argue with you that actually both of these structures are not defendable from an anatomical basis. So let's just talk a little bit about things that we know about. So this man, as far as I'm concerned, was a genius. So this is Mansour Armali, and Armali gave us many, many things while he was prolific in the 60s and the 70s and the 80s. And Armali actually told us a lot about glaucoma genetics. He told us a lot about glaucoma epidemiology. And what a lot of people don't understand is that he made a terrible invention. He gave us the cup to disc ratio. He invented the cup to disc ratio in 1962. And so this is one of, unfortunately, not his greatest inventions, in my opinion. And I'll tell you why. So we have been embarking on an exercise where we are incorporating OCT findings to the clinical examinations. And one of the first questions that we ask people who take part in this exercise is to say, please tell me what you think the cup to disc ratio in this eye is. So we provide them with a stereoscopic view, and they can look at this in stereo. And I'm just curious to see what the variation of so-called experts is in a cup to disc ratio. Now, I've done the exercise now, actually in many countries. And I'm going to show you examples from 3 countries, from Sweden, from Brazil, which we did actually just very recently, and in France. And I find it staggering that the response is across the whole range. There are people who think that the cup to disc ratio is 0.1, and there are people who think it's 0.9, and anywhere in between. And in fact, all the countries have this variation. It's not that some people do better than others, some countries do better than others. And the sad part is that even glaucoma specialists have this degree of variability. So whether you show it to trainees, whether you show it to general ophthalmologists, whether you show it to retina specialists, or whether you show it to glaucoma specialists, the variation in what individuals think the cup to disc ratio is staggering, staggering. Now, I say to you, if we teach our residents to write down the cup to disc ratio in the charts, what on earth are we writing? If we have this degree of variability, so if we have a patient and I say to Alex in Brazil, Alex, this patient has a cup to disc ratio of 0.2. Alex looks at it and says, oh, I think it's 0.8. I mean, and we are making clinical decisions made on these observations. So please, let's just drop this terrible index that should have been dropped in the 60s, even before it was invented. But in fact, it's worse than that. So the other part of the exercise we ask people to do is, okay, now that you've told us what the cup to disc ratio is, tell us where you think the disc margin is in this particular eye. Okay, so that's the next question we ask. And we give them all the time in the world. They're looking in stereo. They can have a glass of wine. They can listen to Mozart in their ears. They can do whatever they like. They're not in a busy clinic with 40 patients waiting outside. And this is what the heat map of the disc margin looks like. Okay, so now you may say to yourself, these people in the middle, I don't know what drugs they were smoking when they did this, but I have not, even if you ignore these guys, okay, just look at this horrendous variation in where people think the disc margin is. In this eye, which I think actually is relatively easy. The fun gets even more when you ask them where you think the cup margin is. And that's what this data looks like here. So this is what it looks like in the red. So that's what the heat map looks like. So how on earth can we actually make any quantitative measures based on this? So this is clearly not the way to go. Okay, so let's just have a look at what the salient anatomy is, and then we can really talk about how OCT is helping us. And I hope that my slides will work. So these are the salient structures that we need to look at. So, so at the optic disc margin, the clinical optic disc margin, really the structure that we're interested in is this one, which is the Brooks membrane opening. And Brooks membrane opening occurs, there's a break in Brooks membrane to let the optic nerve axons come out of the eye to form the optic nerve. And so in OCT, sometimes you can tell between the RPE and Brooks, but often it's referred to as the RPE-Brooks complex. And as I said, sometimes you're able to distinguish between the two, but frequently you can't. And you have this border tissue of Elschnig, which has various configurations depending on where you are in the nerve head. And we'll talk about this a little bit. But the structure that we're really interested in is this one, which is called the Brooks membrane opening. Now, we can see this anatomy beautifully with OCT. And this is an old slide with spectral domain OCT, and the quality of this gets better and better. So here we see the border tissue of Elschnig, which is in this what's called an internally oblique border tissue configuration. Here's Brooks membrane opening, here's RPE, and Brooks underneath that. So one of the things that we did, and this is one of Alex's studies, is that we asked clinicians to actually look at this disc photograph and tell us where you think the optic disc margin is. And then what we do is we perfectly co-localize the infrared image from the OCT. So these two images are perfectly co-localized, and this is software which my collaborator Claude Burgoyne has developed. So then we can take the optic disc margin in the fundus photograph, transpose it to the IR image, and then we can look within the OCT to see exactly what the clinician is looking at as the disc margin. Conversely, we can actually go upwards, look at the Brooks membrane opening, and translate that over to the fundus photograph. So that tells us now clinically what the disparity between an anatomically tangible structure, which is the Brooks membrane opening, and the appearance of this opening, which is of course the clinical disc margin. So here in the fundus photograph, you can see this dramatic difference between where the clinical disc margin is and where Brooks membrane opening is. And in some places, it actually co-localizes perfectly well. And in other places, there's a very, very substantial difference between the two. And in myopic eyes, this becomes much more of a problem. So in this highly myopic eye, I think that the disc margin is here, where I've put the green dots. And then what we can do is we can take an OCT section along that line, and we can look to see what it is that I'm looking at when I see that that's the disc margin. So as I was explaining before, so we have the Brooks membrane opening points that we can project upwards to the fundus photograph, and we can take the disc margin points and we can project those downwards to the OCT. So this is a really beautiful way to actually correlate what we see clinically on the fundus exam versus what we see in the OCT with this software. So here is the case in point exactly. So if we look nasally at this optic disc, what you can see that the disc margin actually almost exactly corresponds to where Brooks membrane opening is. But if we look temporally, we can see that what the clinician and what I am looking at temporally at the disc margin actually falls somewhere along this border tissue of Elschnig, which is what's called an externally oblique configuration. And I assume that what I'm seeing and what clinicians are seeing here is probably some pigment, which we think is actually the disc margin. But as you can see, it's not a tangible anatomical structure. Now, the actual opening, the actual hole through which the nerve fibers exit through is here. And there is no way that any person is going to say that that's the temporal edge of the optic disc. There's absolutely nobody who will say that. So you can see that just in this one particular scan, what the clinician is looking at as the disc margin are two different anatomically distinct structures. And if we have that, then I would argue we have no business making any sort of quantitative measurements from this. And so the point here is that the BMO is not the clinical disc margin. It is in fact an OCT structure, but it cannot be called the disc margin. And here's another really interesting thing. So just to add to the problems is that clinicians can't see some very critical optic disc anatomy. And I have to tell you that this is the case when Alex was a fellow with us 9 years ago or even more. This was the one case that actually brought us to do this research. And my collaborator, Claude Burgoyne, was in Halifax at the time, and we've been drawing all these disc margins and stuff like that. So here, again, I'm going to show you the fundus photograph here, and this is the co-localized infrared image of the OCT. And the usual exercise that we did is we said, okay, draw the optic disc margin, and we're going to do that. But I want to draw your attention first to this cilioretinal artery, because this is really very, very interesting. You can see that, very common occurrence, of course, in many, many patients. Now, what I then said is, okay, where is the clinical disc margin here? And this is where I would put it. Now, you probably may not agree with me because you may think it's more external than that, but this is where I happen to think it is. And I'm not right and I'm not wrong, and you're not right and you're not wrong, because I can tell you that it doesn't correspond to anything that's anatomically tangible. But let's now mix the OCT with the clinical examination. So if we take a B scan along this green vertical line over here, you can see that scan over here. This is inferior, this is superior. You will all agree that the Brooks membrane here is completely intact. You can see that. So we are very clearly outside of the neural canal. There is no discussion about that. But if I take a B scan here, which is well inside the clinical disc margin, right, where you would think that the axons are actually leaving the eye, well, lo and behold, when you look at the OCT image, the BMO is still completely intact. And not only is this intact, but you can see the cilioretinal artery underneath and above a completely intact Brooks membrane. So this Brooks membrane is actually optically transparent to the clinician. So as you can see, this cilioretinal artery snaking around the Brooks membrane opening, it actually appears to be, one portion of it appears to be underneath Brooks membrane and the other portion is above Brooks membrane. And this is fascinating because axons are actually not leaving the eye at this point because the Brooks membrane is entirely intact. And you can see this here when I show you a higher resolution version of it. Here is the portion of it superior, here is the portion of it inferior. So let's just recap on this. So there's a large variability, there's a large mismatch between the clinical disc margin and the Brooks membrane opening. And clinicians can't see this external edge of the Brooks membrane opening because it's frequently inside the clinical disc margin and it's frequently invisible. And this is going to have a very, very large impact on how we actually quantify the neuroretinal rim. And let me show you how. This is a disc that you've looked at before. And what I'm going to do is I'm going to take a section where this white line is exactly where you can see this portion of the B scan. Now, let's just put in our landmarks here. So this is the projection of the clinical disc margin here, which is lying somewhere along Brooks membrane. And this is Brooks membrane opening, which is determined from the OCT. Now, what you as clinicians do when you estimate the width of the neuroretinal rim is that you look at the clinical disc margin and you take the rim measurement along the plane of the disc margin. So let me show you what that looks like. But first of all, let me tell you that this part is actually invisible. This is the invisible extension of Brooks membrane that the clinician could not see. So the clinician is making this measurement, which is a disc margin based measurement, which is this green one. But we know that axons cannot possibly leave through this space here, which means that the clinician is overestimating the margin, the width of the neuroretinal rim by a factor of 2 in this case. The actual rim width is actually from here, where the Brooks membrane opening is. So in this particular portion of the optic disc, the clinical exam overestimates the width of the neuroretinal rim. And I would actually also argue, because of the orientation of the rim over the Brooks membrane opening, in fact, the measurement should actually be made perpendicular to the Brooks membrane opening and the internal limiting membrane. And this is the measurement that we've called the minimum rim width. And that's now available in the OCT devices. So this is the logic, the rationale for actually creating this new measurement from an anatomical and from a geometric perspective. Okay, so now you can say, well, that's the theory. How good is it? Okay, but before we talk about that, I just want to show you another variation that OCT is teaching us. So here you can see two normal eyes, okay? But there is a very, very fundamental difference between these two eyes. And that difference lies in the position of the fovea relative to the Brooks membrane opening. And as I segment out the Brooks membrane opening here, and I take the angle between the fovea and the Brooks membrane opening, which is what we've called the FOBMO angle, you will see that there is actually a 20-degree variation in this angle between these two eyes. They're both normal eyes, yet there is this very strong anatomical and geometric difference between these two eyes. And this is going to have a very, very significant impact on how we actually parameterize and sectorize the optic nerve head. Let me show you why. Now, if you don't take this angle into account, and if you assume that the quadrants that I'm showing you here are all relative to when the patient puts their head inside a machine and we say, okay, superior nasal and superior temporal are always in this position, then we are actually going to make a tremendous mistake in the sectorization. If we take these two eyes now, this is the one where the angle was 2 degrees, this is where the angle was minus 18 degrees, well, it becomes immediately apparent that these sector maps are actually measuring different anatomical locations simply because of this fovea to Brooks membrane opening angle. So we have to actually accurately regionalize this by rotating in the first case by 2 degrees and placing that sector map on the first eye. And in the second case, by rotating it anti-clockwise and actually placing that on the other eye, so that now we're actually talking about equivalent anatomical locations. So when we talk about superior temporal and superior nasal, we're talking about the same quadrants in these two different eyes. And what we've tried to do now in the software, and I really hope that this actually works, is that I'm going to show you now in real time acquisition. This is with the Heidelberg machine of how this is done. So we define the fovea first of all. So the software automatically detects this with these two cardinal scans. And then the operator simply confirms the locations of these two spots. And once that's done, we're going to go and try to define where the Brooks membrane opening is. So again, we have these two cardinal scans, and we will detect Brooks membrane opening automatically. And then the operator simply has to confirm to make sure that they agree with it. So once we've found the Brooks membrane opening center and we've found the fovea, we've now established this angle in each individual patient. And once this is done, we can acquire all our images based on this individualized geometric axis for each patient. So the acquisition is actually done with this. So the radial scans are done this way. The circle scans are done this way. And then actually we can also do the macula in this way too, because remember that the macula also is going to be affected by this. So as I'm talking to you, all this image acquisition is done in real time. So here are the 61 lines that are done horizontally across the macula. And then we'll also do the 19 vertical lines also through the macula. So this whole acquisition has been done in real time. So we can do all of this optic nerve head and the macular image acquisition based on these individualized coordinates. And not only have we done that, but we've now embarked on a very large project where, and Camila Zangali, who's also in the audience, and Alex and Vital have also taken part in this. So we've gone ahead now and created these normative databases that will be incorporated into the software. And our plan is to have about 2,000 eyes with this new acquisition system within the software. Okay, so the question now is this new approach clinically useful? This minimum rim width, is it better than what we're doing so far? So let me show you, this is a paper now 7 years old, but it's still, I think, quite useful. And we're going to show the utility of this using this ROC curve. Just a reminder that the ROC curve is a way to look at the diagnostic performance of a test by looking at its sensitivity and specificity. And we're not really interested in any part of this ROC curve that gives us low specificity. And I would say that we really need to start looking at sensitivity values at specificities of 90% or higher. So now let's go back to the bad old days of disk margin evaluation. So I'm going to show you the Hrt analysis now. The Moorfields regression analysis, for those of you who are old enough to remember the Hrt, had this Moorfields regression analysis where it gave you this classification of within normal limits, borderline, or outside normal limits. This is the rim and the cup margin and the disk margin that have been defined by the machine. Now, we can have two classifications when we have a borderline. We can make it a very conservative one, where we take all the borderline data and put them within normal limits. And when we do that, we have a single point on the ROC curve, which is here. So it has about 90% specificity, but unfortunately, it only has about 55% sensitivity in this population that we tested. Now, we can make the test less conservative and take all our borderline cases and make them outside normal limits. So that's a more liberal criterion. The liberal criterion, of course, will give us a higher sensitivity, but at the loss of specificity. So this is what you see here. So our specificity has gone down now to 70%, but the sensitivity has gone up to about 75%. If we now take this measurement with Brooks membrane opening, but we make it along the plane of the BMO reference, this horizontal measurement here, we actually find that that does more or less the same as these optic disc margin-based measurements. So it's no real improvement. But actually, when you take this minimum rim width measurement that we've described, you suddenly see a very large increment in the diagnostic performance. So you can see we have a very large increase in sensitivity at a given specificity. And in fact, it does, particularly in this population, it does better than a nerve fiber layer thickness as well. But as you can see, this is the first study that showed this. And we actually have many subsequent studies in the years, and I'm sure there's many, many more studies that have shown this, that essentially show that the optic disc measurement based on a minimum rim width is at least as good, if not better, than a nerve fiber layer thickness measurement. So this to us was a very positive way to show that optic disc rim measurements that are made in this correct way actually are diagnostically much more accurate. So let me summarize and say that the disc margin is not an anatomical defensible entity. And I hope I've shown you enough slides to prove that's not the case. What the textbooks tell us, that the disc margin is at the edge of the border tissue or at the edge of the scleral flange, is just simply not true. It's highly variable. Not only is it variable among individuals, but it's actually variable within a given eye. And it's variable, as I showed in that myopic eye, even within one B scan, it's variable. So clearly it has no anatomical defense. The disc margin, because it's not consistent, we can't actually make any quantitative measurements of the neuroretinal rim. The BMO is, because it's readily visible with OCT, but unfortunately, clinically, it's not, because it's clinically and photographically invisible most of the time. And the diagnostic performance of these BMO-based measurements is actually higher than the optic disc measurements. And it's also, I've not had time to show you in this presentation, but it also relates better to the visual field. Now, all of these ideas have been summed up in this paper that Claude and I wrote. It's like an editorial in the AJO. I still think it's a valid paper, although some of the things in here are not really old. But the point that we want to try to make in this is that we really should not look at the OCT in isolation from the clinical disc examination. And this is the paradigm that we propose. Every patient needs to have a clinical disc exam done with ophthalmoscopy, with photography, if you're lucky to have photography, or a slit lamp biomicroscopy, because there are so many things in the clinical disc examination that an OCT will never be able to tell you. You'll never be able to look at the real color, which is so important, that you can only get in a clinical disc examination. You will not see disc hemorrhages very readily on the OCT or any devices, and you really need to see that. You need to look at the texture of the optic nerve head and of the neuroretinal rim, which frequently you cannot see with OCT examinations. So the disc examination is absolutely critical to do. And I would argue that not everybody needs an OCT examination. Discs that are grossly abnormal or grossly normal probably don't need an OCT examination for diagnostic purposes. You may need OCT to follow those patients, but not for diagnostic purposes. So in those eyes that you're unsure about, this is where OCT can really help you, right? So if you do OCT imaging, you can incorporate the clinical disc examination to the OCT imaging to make actually a quantitative analysis to incorporate the knowledge of the anatomy that you know. And together, you can make going from a disc examination to a clinical assessment of the optic nerve head. And the point here is, if there's only one message that you take away from my talk, is that the OCT examination is supposed to enhance your clinical evaluation. It should never, ever replace it. I hope you're not in a situation where the technician brings you a printout from the OCT and you don't bother to take your 90 diopter lens out to have a look at the nerve, right? Sadly, I know ophthalmologists, even in this country, who do that. They don't bother to actually look in the eye and actually think it's a good idea not to look in the eye because the machine is so much better than the clinical examination. And I would argue that you don't do it, and I'd argue that you never teach your residents to do that either. So OCT is just a tool, like your ophthalmoscope is, right? It's a good tool, but it's not going to replace you. And that's the final message. So thank you very much for your attention. I do apologize for the hiccups at the beginning. My computer clearly was tired. So it needed to be restarted. So thank you very much. And I'm very happy to take any questions with pleasure. Thank you,
Okay.
Alex. Thank you to everybody for inviting me.
Thank you very much, Balan. That was no problem at all. Thank you very much. It's always a clear message that you bring to us. And I would like to call my fellows here to make questions. Should we start ladies first? Camila? Okay.
So, I have a question about detection of progression using MRW. So some experimental glaucoma data shows that MRW loss precedes RNFL thickness thinning loss. However, in clinical studies, we see a lot of variation in MRW data, which may affect the capacity of the parameter to detect progression. And I use spectrolysis by clinical practice, and I often use RNFL thickness to detect glaucoma progression. But MRW, I feel a little bit uncomfortable because I feel it varies a lot, even in normal patients. So I was wondering if you could talk a little bit about the reasons why this is so, and what are the implications to detect progression with the parameter? And so how do we stand in terms of using this parameter for detecting glaucoma progression?
So Camilla, thank you for that question. So let's talk first about the experimental data, which I think one has to be very careful looking at experimental glaucoma and clinical glaucoma. So, Claude's group has shown, and Brad Fortune, who you know, has shown that that changes in the MRW precede those in progression, in monkey glaucoma in progression compared to the nerve fiber layer thickness. And he proposed that these are conformational changes in the optic nerve head. So these are mechanical changes which will be translated into the MRW. So these are proceeding before you have neuronal loss. So these are connective tissue changes that are occurring before you see frank neuronal loss. Now, does this actually happen in human glaucoma? There is conflicting data. There is actually data that support that observation. For example, Chris Leung's group has shown that to be the case as well, and other groups have also shown it. Why is MRW more variable? Well, I think one of the reasons why it's more variable is that unfortunately, the vector of the BMW is not fixed. as you know, right? So you could have variations in that vector that could give you, so the vector can be like this in one exam, and it could flip and be in another direction. So anatomically, you're measuring two different things, and that could also be dependent on your scan quality. So from my standpoint, anything that shows a change is a change, right? Whether it's a neuronal change or whether it's a conformational change, it's something that's not normal, right? So I would take that as a change for sure. As far as the sort of clinical evidence goes in terms of whether one is more sensitive than the other or not, I think the data is very mixed, Camilla. I think that there are some groups that show that it's, it's more sensitive, and others show it's less sensitive. But my advice would be that if you're more comfortable looking at the nerve fiber layer thickness, you should go ahead and do that. The other thing also to bear in mind, and we've shown this recently, is that, at least in my opinion, there is more non-neural material in the neuroretinal rim than there is in the nerve fiber layer, right? So you are having, you may be having loss of neural tissue within the optic nerve head, but somehow that's being filled in by glial tissue or scar tissue. So you may not get this large change in the rim, right? Whereas in the nerve fiber layer, we think that change is much less. But again, it really depends on what you feel comfortable with. But I think at the end of the day, they should be measuring the same thing because it's part of the same, but they don't, because we make this mistake that everything that's in the neuroretinal rim and that's in the nerve fiber layer corresponds to neural material when actually it's not. It's blood vessels and glial tissue and so on. Yeah. So I hope that answers your question.
It does. Thank you.
Sunny, do you want to make any questions?
Sure. Well, once again, thank you for your presentation, Dr. Chauhan. It was great, as always. And I have some, I have a specific question, but I'm very happy to see your last slides where you talk about the clinical evaluation of optic disc photography, because many times some colleagues, specifically general ophthalmologists, believe that machines can substitute retinal images, optic disc photographies, instead of evaluating some of the very important parameters such as disc hemorrhage, peripapillary atrophy, and also the subjective evaluation of retinal nerve fiber layer. And one thing that in the same direction of those questions from Camila is the comparison between RNFL measurements and minimum rim width measurements. We know that there are some difference between studies in the ability to detect glaucoma. But one thing that I want to know is your comments is about the long-term variability of measurements. Because we know that when you talk about topographic parameters, factors such as intraocular pressure and also the vessel diameter may influence a lot. So I would like your comments about that.
Yeah, that's a very good point. So it's very clear. I mean, we know, for example, that the rim measurements and actually even the nerve fiber layer measurements are actually exquisitely sensitive to intraocular pressure. So we can track variations in intraocular pressure, and they can actually explain the variations that you see actually in the minimum rim width. And this probably has to do with the mechanical influence of intraocular pressure on these tissues, which are probably compressible, and that's the reason why you have these variations. But it's very difficult to actually quantify these variations and try to compare them. And unfortunately, the only way we can do that is to actually see which of these can actually detect progression earlier than the others, because by detecting progression, that change is happening over the variability, right? So are the rim measurements more variable than the nerve fiber layer measurements? And I'm not sure I know the answer to that question, and I'm not sure that one can actually compare them fairly, right? You also have to bear in mind that some of these measurements actually have a floor, right? So we know that the nerve fiber layer measurement has a floor. The nerve fiber layer measurement seldom goes down to 0. We know that there is a floor, and that this floor actually is variable among different patients. And it probably, again, has to do with the remodeling that happens in the nerve fiber layer. And it also happens in the rim as well. We see this variation. So I honestly, I don't know what the answer to your question is. I think it's a very difficult question, but at the end of the day, I think that the measurement that you should use is the one that you're most comfortable with, and probably not worry so much if the other measurement doesn't tell you what you expect it to tell you, because sometimes things don't agree. It's very much like the visual field and the optic disc. When the visual field and the optic disc don't agree with each other, you sort of think, oh my gosh, I'm doing something wrong. But we know that the disease expresses itself and its progression in many, many different ways. So I think, again, like Camilla, if you have more faith in the nerve fiber layer thickness, that's what you should use. I don't think there's a right or a wrong answer.
Okay. Thank you.
Vital?
Well, Bao, great to listen to your talk again. I mean, we were discussing before the problems of lecturing to an audience that we're not seeing. But Bao is the type of guy that will lecture anywhere, and people will keep on paying attention to whatever he says, because he's so didactic, and everybody loves his lectures. When he came to Brazil, he was a huge success. So don't worry, Bao. The lecture went fine. It was just perfect.
Thank you very much.
Now here comes a question. Everybody was concerned about progression here. I'm still coming back to diagnostic accuracy. And the question here is specifically the group of patients where you have peripapillary atrophy. Those guys where the BMO is far away from what you think the clinical margin should be. Anyway, where it is. The thing is, in those guys, I know that you have comparative studies with myopic patients. And we know that some of them might have that the peripapillary atrophy, but not all of them. My question is, in patients with an important area of peripapillary atrophy, how is the diagnostic accuracy of BMO MRW compared to RNFL thickness in those guys? A sub-question for the same comment is there a subgroup of patients where you would recommend peripapillary retinal nerve fiber layer as a better diagnostic tool than BMO MRW?
Great, that's a great question, Vital. So let me just start off by saying that in myopic eyes, everything is difficult. Okay, so you have this situation where, as you rightly said, in these eyes, one of the examples that I showed you, where the BMO is displaced so far temporally, when there's very, very externally oblique border tissue configurations. In those eyes, because there is this displacement, it's frequently very, very difficult to see where the BMO is, simply because the RPE Brooks membrane complex appears to have fused with the border tissues. It's not that clear as it is in eyes that have an internally oblique border tissue configuration, where you can clearly see it, that the RPE Brooks complex is nice and thick and juicy, and you can say exactly where the BMO is. In these eyes, number one, because there's a lot of pigment that the OCT can sometimes pick up, you can have many candidate spots where you can actually have the BMO. And, we struggle with it. In fact, we are having discussions actually every week, in these myopic eyes with Claude's group and others, trying to come up with a paradigm that can help us decide where the BMO is in these myopic eyes. So it's frightfully difficult. Let me just tell you that to start off with. And, if we want automated algorithms to be able to do that, it's going to be a challenge. So you rightly say, okay, in those cases, why do we even bother with the MRW? Why don't we just look at the nerve fiber layer thickness measurement? Because we know we can trust it. The problem with the nerve fiber layer thickness measurement in those cases is that your scan circle has to be pretty big, right? And then the question is, well, where do you place your scan center, right? So I'm arguing and saying, okay, everything should begin at the BMO center. Okay, so now you're telling me, well, you can't really detect BMO center, so where are you going to put your scan center for your circle scan? So if there is variation on where you're going to put it, I would argue that you're going to have variation in the measurement of your nerve fiber layer thickness as well, right? So with myopic eyes, you just can't win, right? So maybe the way to go in the future in these myopic eyes is to actually forget circle scans. Maybe what we need to do is to, when the OCTs get really, really fast, we can probably just do an isotropic scan of the whole posterior pole, and we can map out what the nerve fiber layer thickness is, right? And then figure out some way to actually compare and create normative databases. It's going to be enormously difficult. So, while I agree with you 100% that it should theoretically be better to do a nerve fiber layer thickness measurement, if you tell me this is where you should be putting the BMO, where you should be putting the nerve fiber layer scan center for each eye, I'd be much happier to agree with you. But we're not there yet. We can't do it, sadly.
Actually, I was thinking about going to the macula in this situation and forget about the peripapillary or BMO MRI.
Yeah, well, Vital, that's another discussion altogether. If you ask me again next week, we can talk about the macula. But the thing is that, yeah, I mean, even the macula in myopic eyes is extremely complicated.
I know.
Very complicated. But, these are all issues that we struggle with in myopic eyes, and somebody has to come and say, look, when we do research studies, please don't exclude eyes that have more than 6 diopters of myopia, which is what all studies do, right? We conveniently forget about those eyes. But the reality is that these are the ones that are giving clinicians the most difficulty. And it's really time to start to study myopia seriously. Yeah. So great question. Great question.
Okay, well, we have some questions here in the chat.
Sure.
I would like to read one of the questions for you and also my question.
Sure.
Is it possible to tell a rule that, okay, for small discs or big discs, MRW is not good? Okay, don't go with MRW if you have a big disc or small disc. There is such a rule or advice that you could give us. Okay, BMO MRW is not good to large discs whatsoever.
So it's a great question. So I don't know if Lucas is on the call. Maybe Lucas should answer this question because this is his work. So when Lucas was here working with Jaime, this is exactly the project that he did. So let's just go back for a second. So the classification that's made, when you have within normal limits, borderline or outside normal limits, now that has been corrected for the BMO size. Okay, so we know, of course, that Lucas is here, so maybe he should answer the question. Of course, BMO MRW is related to the BMO, so the classification actually corrects for that, right? But Lucas, nice to see you. Maybe you want to answer this question.
So, hi everyone. Thank you for having me here, participate in the discussion, and thank you, Bao, for one more brilliant lecture. It's always a pleasure to listen to you. So, in regard specifically to Alex's question, we've studied a group of patients with different BMO areas, and analyze the diagnostic performance of both RNFL and minimum ring width. And to go straight to the point, what I think I should mention here is at the end, when we analyze the additive value of minimum ring width and RNFL, we've seen that both can flag patients that were not flagged by others. So But let me just open it here. But this varies as a function of the
BMO size.
Of the BMO size, right? So this study suggests that we should use both, but again, they vary according to the BMO size. Yes.
Okay. Well, also, Jaime is performing a study where he's recruiting people to evaluate some case.
Yeah.
Could you give some summary or an idea what if is this study? Because a lot of people here in the audience are taking this exercise, and should you just give us a little?
Sure. So Alex, I'm just looking here. Jaime is on here. I think Jaime should be brought on because this is his study. So maybe Jaime can explain this because this is his baby. Can you bring him on? Is it possible?
Augusto?
I'm not finding him here.
He's there, Jaime Viana. I see him.
Ah, yeah, I see that.
Yeah, I'm sure that Jaime would be very happy to tell you about this. There he is.
Welcome, Jaime.
We cannot see you, Jaime.
There he is.
Okay, there it is.
Hi, everyone. Hi, guys.
Hi,
Thanks
Jaime.
for the great lecture. Happy to be with you. So thanks for the chance to talk about the study. The study is really interesting, in my opinion, of course, because we want to get an idea of how variable people's opinions are, right? So if you see an OCT and a field and a photo, and you look at that and you judge, I really think this patient has glaucoma. I think this patient has, say, 80% chance of having glaucoma. But maybe if you ask somebody else, a person may have a different opinion. And one of the first things of the study is really to get this idea about how variable this is. So each case in the study will be evaluated by 20 glaucoma specialists. Because some studies do this with kind of 3 glaucoma specialists, right? We may see sometimes, oh, each case in this study was defined by a consensus of 3 people. But well, is 3 people enough? We don't have good evidence to know if 3 people is enough or not. So in this study, we're gonna go to 20 people and then see how variable this is. And in the end, the goal is to identify which objective markers in the visual field and the OCT are the stronger predictors of the consensus opinion of these 20 glaucoma specialists. So we are really looking forward to everybody's collaboration, right? To all the glaucoma specialists here in the crowd. We would really want you all to participate. Many people from more than 20 countries already participated, and we're having a lot of good feedback. People are enjoying, people are finding that this is an interesting exercise even for themselves to learn. And you will be able to later go back and see, well, this case that I thought had a high likelihood of glaucoma, what did everybody else say in this case? So later, when we finish the study, we'll have this other chance for you to go back and review this as well. So I really hope that many of the colleagues there in the Brazilian Glaucoma Society can collaborate. And if anybody has any questions, feel free to reach out to me directly as well.
Thank you, Jaime.
Very nice, Jaime. I will ask if anybody in here has more questions. Visani.
Yeah, it's a more practical question because this wonderful parameter is not available in all OCTs. So is there any perspective to, because as we know, RNFL measurements are more democratic. I mean, we have in all instruments, and how to overcome this difficulty?
So that's a very interesting question. Now, we've had many discussions with the team at Zeiss about this over the years. And they've been very interested in the work that we've been doing. And, we're open to talking to every company. It's not that, we use the Spectralis simply because we have it, but, every device theoretically is capable of doing it. So at the beginning, we weren't really sure how the Zeiss instrument was actually reporting the rim width or the rim area. So, in the subsequent discussions we've had over the years, they have at least told us that they are actually making a similar measurement. They're making a minimum rim width measurement. So at least this is what we are told. I must say that we have the Zeiss machine in the clinic, but I haven't done any research with it, so I'm not the expert to tell you that. But at least from what they have said to me, at least the Cirrus is measuring minimum rim width as well. I don't have enough information on the TopCon devices and the other, the different OCT devices and what they're measuring. So I don't really know, to tell you the truth. Yeah. So, but all this information is in the public domain. It's not proprietary. Everybody can use it to make it. So if you have a machine that doesn't give you an MRW measurement, you should talk to those instrument manufacturers and ask them what it is that they're actually measuring, which is important, of course, for you to know. Yeah.
Okay, thank you.
I think Vital has another question.
Yeah, that's a conceptual question here. Bal, you emphasized the importance of clinically evaluating the optic nerve, and at the same time looking at the OCT, and even in some cases the OCT would not be necessary.
Exactly. Yeah.
In eyes where you are sure that the optic nerve is good or glaucomatous.
Yeah.
But let me ask you a very specific question. In a glaucoma suspect, in an eye that was sent to you for you to analyze, do you think that the diagnosis and follow-up of this patient with a suspicion of glaucoma is adequate without an OCT?
Probably not. So if you have an eye that has a suspicion of glaucoma, it's actually those eyes where you're sitting on the fence is when the OCT is really going to provide you with the most information. So, uncertainty actually gives you information. Whereas if you're almost completely sure that the eye is normal, then the OCT is not going to add anything. If you're sure that the eye is abnormal, for sure, then the OCT is not going to add anything. So it's really in the middle, that's where you get that information. So from a diagnostic perspective, and I use the word diagnostic in rather loose terms. What I mean is for a single examination. So the first time you see that patient ever without anything else, you have to make a decision. Do I send this patient home and say, I don't want to see you for 10 years? Or you need to come back because we need to do your fields, we need to do your CCTs, we need to start your own treatment, blah, 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 okay? So that's a different question altogether. So I'm just telling you, how can the OCT help you make that decision as to whether you need to have more vigilance or less vigilance in this patient? So in those uncertain cases, for sure you need it. Now, if the eye comes to you with a clearly notched out rim with disc hemorrhage and with a field defect, well, you're going to need the OCT to do the follow-up. So it's not a question anymore of whether the OCT is valuable or not, right? So in those particular cases, it's pretty clear cut. So in the cases where you're uncertain, that's where I think the OCT can really, really help with single examinations. Yeah.
All right. Okay, great. Any more questions?
I do.
Okay. Okay.
Can I, take the opportunity, because Jaime is also here, and I know he's a lot interested in this, and I want to see Bal's point of view on that too. I've heard Jaime talking about it, about this, and writing about this. Artificial intelligence, AI. Bal, what's your take on AI? Where do you think we're heading to? Do you believe in structure, a combination of data, structure-function combination of data? Where do you think the future of AI in the diagnosis and follow-up of glaucoma patients is?
Okay, so let me start with a disclosure. I have two disclosures. One is that I'm not very interested in AI. The second is that I really think that it's going to have a place in the future. There's no question, right? There's no question that it cannot be helpful because it's been used in so many other fields. Our computers getting powerful, we're getting smarter. So clearly AI has a very, very important place. I just, from a personal standpoint, have not invested the energy into doing AI, simply because I just have other things that I'm personally more interested in doing. But I remain completely agnostic with an open mind, because I do think it has a lot of potential. But one of the things that I would ask all proponents of AI, and I'm going to ask Jaime to come in because I know he's a proponent, but one of the things that I would ask people who are keen on this technique is to please understand what it is that the AI is actually doing, right? What is inside that black box that's giving you the information that you think is clinically useful? Because we now have an era of a lot of software packages now that are AI software packages, and people just put all this data in and boom, out comes the output. And you go, whoa, that's very interesting because, that's not the question I was asking, but it's telling me, this very classic example of this very large study that was done to detect diabetic retinopathy. And in fact, the AI ended up predicting which was a male fundus and a female fundus much, much better than it was predicting whether the patient had diabetic retinopathy or not. So we need to ask what the AI is actually doing, what's behind the black box, right? But I think it has tremendous potential. And I think that it will happen because, your cars and your fridges and your microwaves are all working on AI now. So I can't imagine that it's not going to be helpful in ophthalmology. So Jaime, I'm sure you're keen to answer as well.
No, I think you expressed well your opinion and our opinion. Like, we certainly it has potential. I already talked with the guys from the Brazilian Glaucoma Society about this topic before. And I agree that within the principles of a good, reliable AI explainability, right? The ability of the AI to tell us why it's making that decision. It's one of the things that we expect in good AI models, for sure.
I would like just a question regarding the ER, the eye, and I saw one paper from IBM, from Australia IBM, from +One, showing something very interesting to diagnose glaucoma is that the hot spot where to make the diagnosis or not is the nerve, the retrobulbar nerve. There's something that we never saw by OCT, and it starts showing something that we might looking at. So I would like to have your opinion on that. Should we look further? Should we look at the retrobulbar nerve as also a tool for make diagnose? Because I've never seen somebody doing that. But the black box showed that it might be a place to look at. What's your idea on that?
So Augusto, I just want to make sure I understand you. When you mean the retrobulbar nerve, do you mean the retrobulbar nerve with an OCT exam, OCT, or the retrobulbar nerve OCT. With an OCT exam? Yeah. Well, okay, so again, I do believe that, of course, the retrobulbar nerve is extremely important because it's the deep optic nerve, and the deep optic nerve, in my opinion, is retrobulbar. And I think that certainly the deep connective tissues in the optic nerve head, the configuration of those tissues, particularly in relation to the sclera, are extremely important. The problem, while I think it's great to look at, the problem is that a lot of the OCT devices are not able to image those structures reliably. And that's because there's very little signal penetration in the deep optic nerve, because you've got a lot of opaque structures that get in the way. So how can we do that? Well, we can do this with swept source OCT because it uses a longer wavelength light. So the theory is that at least these devices that are using 1050 or 1020 nanometer laser sources will be able to penetrate much, much deeper. So that's one hopeful thing. Faster scan rates are also important because faster scan rates will increase the signal to noise ratio. That will allow us to do that. But the problem, unfortunately, is that if you've got a small BMO, you've essentially got a crowded nerve, you've got a lot of pre-laminar tissue, you've got a lot of blood vessels that are going in there. You know, no matter what type of laser source you have, you're going to get a lot of laser attenuation for you to be able to image those structures. So while I agree with you that ultimately we want to go there, I would be much more persuaded if we are able to image those structures reliably in every eye. One of the things I would ask you to do is to look at those eyes that they looked in that study. And I wonder if those are eyes with very large BMOs where you could actually get signal penetration into the deep optic nerve to be able to see these things, right? So one must ask that question because, you know, it's very much like these papers that talk about defining the posterior border of the lamina cribrosa, right? You know, I must be an idiot because I actually can't see it. You know, people talk about, oh, you know what, we measure the laminar thickness. And I think, well, how, you know, we have a difficult time segmenting the anterior laminar surface, and you're telling me that you can do the posterior laminar surface? It's difficult, right? So some people can see it, I can't see it. And I think it all depends on you know, what type of eye it is, right? And whether you're able to do this reliably. So again, you know, when you said retrobulbar, I was wondering whether you was talking about doing MR imaging, because of course there are MR studies that are showing
we published one in IOVS.
Yes.
We can see difference, but using this as a diagnosis tool it's not worth at all. But it's we can see difference. I was amazed. I agree with you. I was amazed with this paper that the algorithm find out that looking for the retrobulbar nerve by OCT, you can differentiate from glaucoma and normal patients. I agree with you. It's something very strange. I agree with you that also it's very hard to see anything there. But maybe in the future, because it's everything crowded there, you're losing everything, but you have an idea of what's there because it's crowded there. I don't know. It's just interesting to see that the machine is looking for that some in a place that we've never thought about.
So sometimes, Paranhos, what may happen is if you have a very cupped disc, you have some more signal in there. It doesn't mean that that signal in there is really something in the retrobulbar nerve, but it's just more shadow and less shadow in that region.
Yeah.
And then the machine just identify, well, more cupped or less cupped discs. And that is more or less reflective of the shadow in the retrobulbar region. Not that that scan had quality enough to obtain some anatomical information of the retrobulbar nodule, but it was a reflect of what is happening more anteriorly. Right? So that's one problem. We don't really know what it was seeing there.
That's the problem. That's the black box problem, because it could be actually looking at something incredibly simple, you know, like the BMO size. We know already that there is a selection bias in most studies that glaucoma patients in clinical studies have a bigger BMO. Well, we know that if we go out into the population and you screen, you know, 1 million people, I'm almost certain that the BMO area in unselected glaucoma patients is no different from controlled subjects, but they are in a clinic because large BMO is related to a large clinical disc margin, and a large clinical disc margin is related to a larger cup to disc ratio. Boom, that's where you have your selection bias, right? So it could be something as simple as that, you know?
Yeah.
Okay, nice. Mal, I have one last question before
you can ask as many. You can ask as many as you want. I'm awake now.
Okay.
I told Alex that I go to bed quite early, and whether I could give my talk in pajamas, and he said, please don't. So I bothered to get ready, so now I'm fine. So I'm not sleepy at all.
So, okay, and this is about normative databases. I know
Sure.
you're interested, and
Sure.
you've been publishing some papers on this topic. And where are we going? I mean, it's better to have a large normative database or individualizing normative databases to what is the future of this? Because some people think we have few people in the normative database we have currently. So what are your thoughts on normative database?
Alex, I love this question. Thank you for asking. I really love this question. So we are all making we're making a statement here to say, oh, you know what? If we have black subjects, then we have to look at a black normative database. If we have a white one, we have to look at white. If we have Japanese, we have to look at Japanese. If we have Chinese, in theory, that's all good. I support that. But for the parameters that we know today, right? Nerve fiber layer thickness, minimum rim width, BMO area. Well, not BMO area. Let's just take the two neuroretinal parameters. Let's take the nerve fiber layer thickness, and let's take the and the minimum rim width. The variation that you get within one population, let's say blacks, that variation in the population is so much greater than the average difference between blacks and whites, or blacks and Chinese and blacks and Japanese, that actually it probably for these parameters doesn't make any difference whether you take a Japanese normative database to look at a black person's eye or vice versa. Mm-hmm. Right? Simply because the variation is so big that when you look at that distribution and you want to look at that 95th% cutoff to make your normative classification, the variation is enormous. So you want to be able to have that 95th percentile, right, with the accuracy, with the confidence intervals of that prediction interval to be very, very small. And that's related directly to the sample size, right? So the larger the sample size is, the more accurately you're going to predict what the 95th percentile is. So while we are collecting all this data from the different races, right, it could simply be that at the end of the day, we just pool all of that data together and get a much more precise estimate of what that percentile is, whether it's the 5th or the 95th percentile, right? So that's for the parameters that we know today. But now, if we go fast forward in a few years' time and we say, oh, you know what? There is something about the angle at which the nerve exits the eye in a Japanese population compared to a black population. And we already know that this is the case. We know the configuration of the black BMO is very different from the Caucasian ones, and it's very different from the Japanese ones. We just don't know what parameters to use yet. So it's possible that as we get smarter, these race-specific databases will become more valuable, right? Mm-hmm. But at this point in time, for the parameters that we know, there isn't true evidence that it actually helps. So I would say, great, let's collect this data. If we have to pull the data, then we can make much, much more precise estimates of what those percentiles are, right? So that's our logic going forward with this.
Great, yeah. So any more questions? Okay, I think we are done here. It's been one hour and a half. Well,
sorry.
I really appreciate your time here. Really appreciate picking your brain. Thank you very much for being here with us. It's a pleasure. It's a gift for us, actually. Thank you very much.
It's a pleasure. Thank you very much for having me. And I hope you have a lovely evening in Brazil, and hope your winter is not too unbearable.
Not at all.
Yeah, I laugh because you don't know what winter is. Lucas will tell you. Lucas will tell you what winter is. Lucas was surfing in 0-degree water. So just to let you know.
Oh my gosh. Jeez.
Yeah, he's a bit crazy.
Thank you very much.
Okay.
Thank you so much, everyone. It's been a pleasure. Thank you for having me.
Thank you very much.
Bye-bye. Thank you.
Bye-bye.